Welcome to our new episode of MLTB episode 6. So, here with us today, our esteemed speaker, Dr. Harpreet Singh. So, first of all, we try to introduce our esteemed organization, RSG-India. So, ISCB-SC RSG-India is a short form of International Society of Computational Biology, and it is a student council of RSG, student council of ISCB. RSG India motto is your local window to global opportunities. So here, ISCB-SC RSG India is a part of ISCB, and under which there is a student council, International Society of Computational Biology Student Council, and under there is a RSG India. RSG are the student council part of the ISCB. There are 20 RSGs are organizations which are run by country bioinformaticians. There are 28 plus RSGs in all around the globe. So this is one of the intro of the ISCB. So ISCB first started in USA for maximizing the global impact of computational biology on science and society through scholarship, research, training, outreach, and inclusive community building. Under which there is a student council in which RSG India comes. So as an RSG India, in India there are 3 nodes of RSG India. One in Hyderabad node in which Mahindra University came. Another one is in Karnataka in which Manipal University came, and third one is in Kerala in which NIT Calicut has come. So these are our RSG India core committee members. So this is our 6th episode of MLTV. It is a MLTV full form is Meet and Learn with the Bioinformaticians, in which in the previous 5 episodes, here are the speakers which we came like Raja Majumdar, Michael Timmer, Sudaksha Ganguly from PDB, Professor Samrat Chatterjee from THSTI, Dr. Millet from South Korea, and Professor GPS Raghava from our previous MLTV episode. These are some of the glimpses from our previous RSG India programs, and these are from the MLTV episodes. So I would like to welcome Professor Manish Kumar to come on stage and introduce our speaker, Dr. Harpreet Singh.
Good afternoon, everyone. It's my privilege to introduce Dr. Harpreet Singh. So I know him from a very long time. But apart from our friendship, he is the one, whenever you talk to him, within 15 minutes you will get 10, 15 different research ideas, and then you have a bag full of ideas to work on for next 1 or 2 years. So actually, Dr. Harpreet heads the digital health division of ICMR headquarters. So earlier he was with Biomedical uh, Informatics division. So besides compiling details about projects, sanctioning funds, other things, he has a very vibrant research group also. And his impact on research, you can assess that he has recently published a paper in Nature Genetics, या medicine, and he has recently published a paper in Lancet also, Lancet Public Health. So you can see his impact. So he is the one who was he is behind instituting the gold standard data about different biomedical data like X-ray data, NMR data, all different type of biomedical data. So it's already done and people are using it. Similarly, during COVID pandemic, you have seen lot of things which were coming up about the different diagnostics kits, maintaining the data. So he was the one from ICMR who was managing everything. So how to manage data, which we call as big data, you can learn a lot of things from him. Okay, so on the behalf of Department of Biophysics, I welcome Dr. Harpreet, and I also request you all to don't get terrified by his persona. He is very friendly, so he will answer all the questions that you may have. Okay, so welcome, Dr. Harpreet.
Thank you.
Okay.
Dr. Manish rightly said we know each other for a long time. In fact, we have common mentor. So my mentor was Dr. GPS Raghava, and Dr. Manish also finished his PhD with GPS Raghava. I have not finished. Then I moved to ICMR and then different places, and then finally I'm here. So thank you, Dr. Manish, for having me here. And RSB. So in fact, I would like to tell you I'm a member of this international, this ISCB. Very bad in remembering names. All my project staff and all the staff who work with me, they come first in front of me and tell, sir, this is my name. Now please tell me what to do. Okay. Yeah. Thank you. Are you able to hear me? I know my voice is quite loud. Okay. So I started my career, as I told you just now, with Dr. GPS Raghava as a bioinformatician. So since this talk is about meeting the bioinformatician, so I'll tell you how this transformation has happened. So I started my career as a bioinformatician and then I moved to ICMR. And when I moved to ICMR, the only thing I knew was DNA, protein, and the prediction methods. So I was quite confident that every problem in the world, every problem in India can be solved with DNA, protein, gene, genome, and bioinformatics. But then when I started a couple of programs at ICMR, I started realizing the problem is not that simple. It is too complex to be solved by genes, proteins, and DNA. So in this presentation, you will see very, very minute glimpse of DNA protein. You will not hear the word DNA, protein, gene expression, anything. You will see an altogether totally different world. But believe me, this is the world, no, the area which India requires. I'm not saying the other area India doesn't require, we require, but this is something that can give us immediate, low hanging fruits, immediate results. Why? I'll come in a moment. So let's start with the first slide. So where our digital health journey started. We launched this digital India campaign. I think all of you are aware of that. So one of the biggest achievement of digital India campaign is this payment system. You all are aware of that. And then the widespread adoption of internet and mobile communication technologies in India. As per this TRI report 2024, more than 82 crore internet subscribers are there in India, and out of them, 45% are in the rural population. So we have a very strong presence. So this is the success of Digital India mission. But then the problem is health sector was not included as part of digital health mission initially. Now it is. Then the problems continued, health problems. What are the health problems? You all know, maybe, I don't know, maybe you know or not, but India has a three-tier healthcare system: primary, secondary, and tertiary. The objective is that majority of the population or the individuals should get health consultancy or interaction with the doctor or a medical professional at the primary level. Less number should go at the secondary and minimal number should go at the tertiary level. The common problem, you can see the numbers of primary health centers, sub centers. This all is data taken from various internet sources, reliable sources. The common problem is we have a shortage of trained manpower. This I think you must have heard so many places. Now the research question is how using, because manpower we cannot increase overnight. So the interesting question is how we can leverage the technologies so that with this limited manpower, we should be able to provide quality services to our citizens, to all across the country. When you're sitting here, don't imagine that we are sitting here in a very high-tech research lab and then doing proteins and pipetting. Think about the person who is sitting in the remotest corner of India in a village. He is not able to access the healthcare services. So how we can do that? How we can deliver those services to that person? This is the ideal scenario of our healthcare system. Majority of the individuals get treatment at the primary care center, and then very few are going to the tertiary care center. Very easily you can figure out which one is the primary and which one is the secondary from this picture. But the actual situation is this. I think some of you who are living in villages must have seen this kind of picture. The primary care facilities are underutilized because of so many reasons. I'll not go into that. But the tertiary care facilities are overburdened. This picture is of AIIMS. Extremely overburdened. So now the objective, the program that I am handling, I am program officer at ICMR looking at the area of digital health, artificial intelligence, and bioinformatics. So the major objective is how we can use digital health technologies to fill in this gap. There's a very big gap between primary and tertiary. So to provide equitable, affordable, safe healthcare to every citizen regardless of its location and socioeconomic status. Some of you must have heard of this Viksit Bharat Master Plan by Modi ji. So 2 points I would like to highlight here. One is the telemedicine solutions. There is an emphasis on increasing the spread of telemedicine services and telemedicine solutions. And the second one is multilingual digital doctor. They are calling it as DigiDoctor or eVAD. So as a concept, it looks very nice and very good. You know, it is feasible and it is doable and it is going to be really helpful. But then there are a couple of challenges if we are going to implement digital doctor or develop digital doctor. So people like you are required because you are the brightest future of our country. So one of you is going to develop a digital doctor sometime. So this is the Viksit Bharat very elegantly placed digital technologies to deliver equitable, affordable healthcare services. But then what are the various components? 3 components that I would like to highlight here is smart telemedicine solutions. I'm not saying telemedicine solutions, smart telemedicine solutions. Why they are smart, I'll come in a moment. Digital biomarkers and digital therapeutics. This is another area which is very, very, not very much prevalent in the research community. Not much research has been done in this area. I'll tell you why I'm saying this. And then the personalized robotics assistants. China is doing wonderful work. NVIDIA is coming up with excellent chips. Many companies are coming up with this GPU cards and chips and all. So it is right time now that our workforce, young workforce, should start thinking in those lines. How we can develop personalized robotics, who can provide assistant, who will be kind of a nurse, who will be kind of looking at the vitals of individual and then transmitting that information to a digital doctor sitting in some city or some remote location. So this digital, there are initiatives, some initiatives. I'll touch upon that. And it is not just the government sector, private sector is also very seriously interested in this area. Believe me, I am interacting with many private players. They are very seriously interested. So there will be a lot of job opportunities in this area coming. Now coming to the government initiatives, I'll not take much time on this. You all know about Ayushman Digital Bharat Mission, ABDM. You must have heard of that. Then e-Sanjeevani. Some of you may have used this e-Sanjeevani. It's a very, very wonderful telemedicine portal, but then it has challenges. I'll come in next slide. Then you have this Integrated Health Information Program, IHIP, which is coordinated by NCDC. So it is again a wonderful program where we are trying to consolidate information from various programs of Government of India and then develop an integrated repository. There we can, with this IHIP data, we can do disease prediction, outbreak prediction, surveillance. So many things we can do if we have integrated data. And then there are programs like COVID, must have got vaccinated. Then RT-PCR app, which was very extensively used during COVID. Continuing on that, Ministry of Electronics and Information Technology, MIT, has also started this Digital India mission where number of initiatives, as I said in the beginning, health was not, but now health is a very integral part of this Digital India mission. In fact, after this presentation, I'm going for a meeting in Ministry of Health, where if you search on internet, there is a program called AI Kosha, where data from various health verticals are being collected by MIT and which will be made available to researchers like you for developing quality AI applications. So there are a number of programs by the government of India funding extensively on digital AI, India AI Compute, India AI Digital Platform, which is now called AI Kosha, then India AI Innovation Centers, application development. So many programs government of India has already started. There is now this call for proposal from MIT on developing foundational models. So if some of you are from IT background, they can understand, because foundational model is what we require if we want to sustain or make use of this LLM, this chat GPT kind of technology. I'm not saying chat GPT, but those kind of technologies for Indian healthcare, we need foundational models. Now, why research is required in the digital health? First is to design solutions for diverse languages. We have diversity in our languages, so we need to design solutions, and for low resource and rural settings, to develop, to integrate those solutions, and to personalize and implement those solutions in rural settings. All these areas require research. So these three pillars, if we start working, they will ensure scalability, inclusivity, and clinically relevant solutions for Indian population. So all I'm saying is relevant for developing countries, with an example of India, because we need those kind of, we are a population of 1.4 billion. So we need solutions which should be applicable in the rural area. So, previously I said that there are very little work which is done in the area of digital biomarkers and this digital therapeutics. So these are 6 areas that I think should be applicable to India: intelligent telemedicine solutions, interoperable electronic health records, where NHA is working extensively on it. NHA is National Health Authority. Digital biomarkers, molecular health monitoring. So this is one word where you will see a glimpse of DNA, protein, and other things. Molecular health monitoring. Digital therapeutics. AI-based social media influencers. I'm sure you must have heard of this term. There are papers now coming where these AI-based social media influencers are being used for cancer awareness, for providing consultancy to the cancer survivors, and then cancer individuals with cancer. And then the infodemics. The numbers which are there, first number is, like you say, digital biomarkers, the number you can see is 14, are the number of articles in PubMed if you search on digital biomarkers from India. 990 is the number if you remove the word India. So, and then first article from India came in 2020, and first article in the world came in 2014. So you can see there is a lot of scope in this area to work on. Infodemics is a very interesting area. During COVID, infodemics was used to give wrong awareness about the vaccine benefits or vaccine damages. So infodemics is about disinformation, not misinformation, disinformation. So this is the current eSanjeevani model. Now I'm coming to the intelligent telemedicine solutions. This is the current eSanjeevani model, where you sign up and then you select the specialty that you want to consult, and then the doctor gives you consultancy on the internet through a VC. This is a regular telecom. The challenge here is that, because doctor to patient interaction time remains the same, only thing that we are avoiding is the travel time, traveling of doctor and traveling of patient. But the doctor-patient interaction time remains the same. The doctor asks about symptoms, about reports, then the patient sends him the reports, he analyzes those reports, make clinical notes. But this chat GPT and the LLM models, they have this capacity or capability to summarize all this information and develop clinical notes. So this is where the intelligent telemedicine solutions are coming. AI-assisted clinical notes and clinical documentation development. 2 very large companies are already experimenting on it. Tata MD and Practo, they are already experimenting on it. Then you need AI-based clinical decision support systems. If any one of you have not heard any of the word that I am saying, please ask me, I'll explain what this word is. Okay? Clinical decision support systems for early diagnosis. CDSS, developed by Vadvani AI, has already been implemented in eSanjeevani on trial basis, but it is working. And then you need telemedicine platforms which work on low bandwidth geographical areas for areas where internet is a problem. Then you also need to integrate emerging technologies like AI, AR, VR, robotics in healthcare. So let me tell you this AI based first one is already working on it. Second, already some experiments, trials are going on. But third, I found very little papers on that. And the fourth one, again in an extremely experimental stage. So we need researchers, young mindsets who can take this forward because this is the future. Saudi Arabia has developed a concept of virtual hospitals. If you search on internet, you will find those concept of virtual hospitals. With our kind of population, we need those kind of things. And it is not that we are going to buy the technology from there. We have to develop our own indigenous technology. We have a array of engineers, doctors who are very good at their work. So we need to develop those solutions. So this is the model of smart telemedicine solution that we have proposed. In fact, we have sent a paper on this, where we are using AI for pre-consultancy. We are using AI for selection of OPD, teleconsultation with enhanced interaction. Like doctor gets assistance from the AI in terms of see the patient triaging and in terms of clinical decision supports, clinical notes, and then follow up and post consultancy. So this is a very elaborative model, which probably in another 1-2 years, somebody will take up and develop. When you go to a hospital, your records are taken. We have multiple hospitals. Record from one hospital generally doesn't travel to another hospital. In another hospital, either you have to carry your record on the pen drive or the other hospital takes separate set of tests on you. So to counter that problem, and then there are in India, there are three kind of hospital information systems which are very prevalent. One is this e-hospital, which is developed by NIC. It is approximately in 800 hospitals, it is implemented in big hospitals. Similar numbers is with e-Shushrut, which is developed by CDAC. And then the state governments also have developed their own systems. So how we can integrate those records, how we can make those records available at a one platform. This is where intelligent solutions from the National Health Authority, ABDM, came into picture. ABDM proposed, developed, and implemented two frameworks: Health Information Exchange and Universal Health Interface. Universal Health Interface is actually an API-based platform where different hospitals are putting up their records, and API-based communication is ongoing between different hospitals through this platform. So this is where we are trying to develop interoperable electronic health records, and NHA is very strong on it. And then most of this e-hospital by NIC, they have already been compliant. CDAC is also in the process of getting compliant, or maybe they have compliance by the time, because this is some few months back information that I'm giving. And then the state governments also are kind of enforced to compliance, because this is beneficial for both, for the hospital as well as for the public. Now the next question comes: when you have this millions and billions of electronic health records, how will you use those records? What kind of questions you can ask about it? So these are some of the questions that I have put up. So extensively we can use these records for developing personalized treatments, for developing predictive models, for understanding why we are getting this kind of disease in one particular kind of environment. There are so many applications we can think of. Digital biomarkers and molecular health monitoring. I'm sure most of you are aware how many different parameters this iPhone is capturing data on. This iPhone is capturing data on your voice patterns, on your how you walk, how steady you walk. So many parameters it is capturing data. This blood pressure, so many things it is already capturing. May be correct, may not be correct. I'm not saying that, but it has the capacity or capability to collect that data. Those data points or those data sources can be utilized for understanding the disease pattern, behavior, susceptibility, and so many things. How we can utilize that? There are so many biosensors around us. Sensors. How we can use data from those sensors to understand the disease in our population. This is the area where digital biomarkers, and now there are some developments where, like I have taken this watch, Some sensors are there behind this watch who are capturing, looking at the metabolome of my skin or metabolites of my skin. So those are the kind of developments which are going on, and we need to develop those solutions if we want to provide services, good quality services to our population. Digital therapeutics is a very interesting branch where a software is providing therapeutic services. It is interesting, it is useful, but it is dangerous as well at the same time. So we need not just good development, we also need good governance framework, good regulatory framework on these kind of solutions. Mental health, these solutions have been used extensively. If you look at this picture, this person is sitting and then put up a VR on it, and he's talking to people who are actually not people. They are the avatars of some psychologists or some psychiatrists providing him consultancy, providing him some advices. Infodemics, you all must have encountered this infodemics. In COVID vaccine, we have seen lot of infodemic problems. WHO has recognized infodemics as one of the major health concern, and with 1.4 billion population, 82 crore individuals on internet, so we can understand the damage, the amount of damage infodemics can cause. So we need solutions which can understand this is infodemic, this is misinformation, this is disinformation. It is very difficult to understand, but there are technologies we can do that. Another thing is, since digital health is a very new area, most of people are not very much aware of digital health. So we need to create public platforms to understand the impact and usefulness of digital health. This is what we are trying to develop in ICMR, how we can invite the good minds, or how we can invite investigators who can work in this area. We have published this ethical guidelines for AI, National Biomedical Ethical Guidelines, where we are trying to address some of the problems, but there are many problems which are still remaining. So ICMR's this vision document is available on the internet. Now I'm switching from this futuristic kind of digital health to what actually is there on the ground. Some of the projects or programs that I have done. So I was part of this vision document of ICMR 2030, where there are 3 objectives. We are very serious on how we can make our data, ICMR's data, available to the researchers. Then we are also developing, it is in the final stages, and I'm saying this word, I'm feeling a little bit embarrassed since last 6 months that we are in the final stages, but you know the government system, it is still in the final stages of approval and release. This is a very comprehensive policy that we are developing, wherein we have tried to capture the entire life cycle of data, research data, from planning to dissemination. How ICMR is supporting research in digital health, most of you are aware, we are supporting through, we have actually 4 kinds of funding programs. There's small grants, intermediate grants, Center for Advanced Research, and this NHRP, National Health Priority Programs, and where we are funding these 4 mechanisms. And we are very recently, I had discussions with my DG, and we are going to put up digital health, one of the priority area in ICMR funding. If we can do that, if we are able to, because we have to convince our general counsel. So if we are able to do that, then a substantial amount of funding will come to digital health. This is something that this is the time when I shifted from DNA, protein, gene to data systems. So you can see our Director General, Dr. Soumya Swaminathan. So we opened up a data management laboratory, which was developing solutions for the data portals and database solutions for various programs of ICMR. So that time, this was the requirement. Some of the programs for which this data management laboratory has developed portals. The first one is, you all must have encountered one way or the other, I'll come in a moment, the COVID-19 testing database. So whatever tests were done across the country, that data was captured. So this was the system developed by my lab. Then antimicrobial resistance conservation. Nikusth is another data system that we have developed, which is implemented across the country for leprosy. How many of you know that leprosy is still a problem, or you think leprosy is gone? If you think leprosy is gone, just raise your hands. Oh, you think leprosy is gone? Excellent. But it is not. You will be surprised to know that 65 to 70% of the total leprosy patients of entire world are in India. And this is a very conservative estimate. So leprosy is still a problem, though the number is very less. We have something like 1 lakh, 5,000, 10,000 individuals who are suffering from leprosy, but still it is there. And since the leprosy is a very slow growing organism, it has potential to come back. So we need to close this thing. We need to say that we are leprosy free. So that is where we are working. This portal that we have developed in Nikusth is looking at case-based registration of each individual who has leprosy, then the drug distribution network across the country. We are giving free medicine. Government of India, when I say we, in Government of India is giving free medicine to leprosy individuals. So that entire system is managed by ICMR, by my team, and we are looking for someone who can introduce AI into it. Because there are a lot of medicines who get wasted because they expire. They are sitting in some center and they need to be transported in another center, and somewhere there is a scarcity. So that is where we need AI-based solutions. So if some of you can interested and then come up, we'll definitely work on that. And then there are a number of other, cancer chemotherapy outcome registry, so many things we worked on. This is another project which is very interesting. Number of unidentified dead bodies are found, and then there are a number of missing persons. How you can link those? So this program we developed in collaboration with the Department of Forensic Medicine at AIIMS, and this program has identified in a pilot phase 2 unidentified dead bodies, and then kind of make a closure to the families who are looking for their offsprings or for the missing persons. We are now expanding this program to 8 different centers. Jal Jeevan Mission is another that we have developed. These are basically portals looking at the quality of water across the country. Then this Nikusth I just told you, we are looking at. COVID-19, there were number of databases, number of information sources, and the database that we developed was interacting with approximately 9,300 laboratories across the country, all states. It's a very, very complex system. The beauty is not the system per se, the beauty is the volume of requests that it managed. In a single day, I remember in a single day, we were getting something like 26 lakh, 28 lakh tests done on a single day. So this is the volume of data that was entered, and at the same time, the volume of data that was used by each war room of the state. Another interesting thing was, lot of laboratories were testing, but that were fake tests. So we introduced this concept of QR-based reports, where reports were analyzed for their authenticity by the airport authority and by various agencies. So this system was also developed. Now, interestingly, as I said, there were many systems. COVID-19 portal, this is information you may or may not be knowing. But since I worked in COVID, so I can tell you firsthand what I have seen. COVID-19 is capturing information about the deaths of individuals because of COVID. COVID-19 testing is looking at the testing done, and COVID is looking at the vaccination. So using this information, can we calculate the efficacy of vaccination? Yes, very much possible. But the problem is COVID-19 and COVID testing database has a common identifier, but there was no common identifier with the COVID database. So we use these different methods. You know about fuzzy matching and all those things. And we came up with these numbers. Approximately, if we go a very conservative estimate, 9 crore individuals we found where we can track down when that individual got vaccinated, when that individual became first positive, second positive, if anything happened to that individual. So 9 crore is a sufficiently good number to come up with the vaccination efficacy data. We developed that, and that vaccination efficacy was available on the Ministry of Health's platform, which we used to update. And the first paper published on vaccination from Indian side was again from my group. And we have shown that this vaccination efficacy is approximately the parameter is different. Vaccine effectiveness in preventing mortality. First dose was 99% and then second dose was 99 point something. So it was highly effective in preventing mortality, not positivity. And then this COVID system was used. I've seen this for identification of outbreaks, hotspots, marking containment zones, contact tracing. In fact, your Arogya Setu app and so many other apps were taking data from this testing database, identifying vulnerable groups, guidelines, and then so many things were done, breakthrough infections and all. Now switching gears to a very different kind of area, artificial intelligence. We all know that it's a very big boom. Everyone is talking about artificial intelligence. There are a number of health applications in artificial intelligence. Now, when we say artificial intelligence, we blindly see that we take data from some doctor and engineer collaborate, take data, develop a AI algorithm, put it up in a hospital and say that this algorithm is 80% or 90% accurate. It is showing an ROC of or AUC of 0.87, 0.82. Does that mean something? No, it doesn't. When you say validation of AI-based applications, there are actually 4 levels of validation. It's not just that you see the sensitivity and specificity and that's all the application is done. There are many places where there are challenges. First big challenge is the data, which is used to develop that application. That application may be very useful in a particular given setting or a given environment, but it may not be expandable to the country. This is what is happening with our AI ecosystem. We are developing applications which are very, very effective, very useful, but when you put up in clinical part or clinical deployment, they doesn't perform that well. So there are a number of steps. Interestingly, this last one, post-training model poisoning. I'm very interested in this. There are no agency who is categorically, specifically looking at this particular area. Post-training model poisoning is we have developed a model, we have implemented that model, shown the accuracy, that is working absolutely fine in hospital, but for some cases, the model starts behaving funny because it has been poisoned. It's not corrupted, poisoned. There is a difference between poisoning and corruption. So when the model is poisoned, and some records are showing different, so you can imagine what havoc it can create. Someone who is having cancer, the model will predict is not having cancer. There are many methods by which this model poisoning can be done. There are some backdoor attacks, adversarial attacks, so many attacks can be done. Deliberate. Yes, it is deliberate. Some hackers, they are interested in just creating mischievous activities, but this happens at the cost of individual. So I put up in so many meetings that AI is a wonderful technology, but with great power, it has great power. With great power comes the great responsibility. So we have to be very careful. So next line I say, let the God be with you. Because when you use AI, many a times it is a black box. Many times. Now we have started talking about responsible AI, explainable AI, so many things. But still there are applications. But when you go to responsibility, explainability, you lose on the sensitivity, specificity, or accuracy. So there are so many challenges with AI. Yes. Yes. Corruption can happen deliberately or vese, usually, but this poisoning is done most of the time deliberate. Okay. So when you develop AI applications, one of the primary requirement is data. Most of the time, and it has been recognized across the country, this development happens in silos. That is where I'm saying AI Kosha is a wonderful initiative by the government of India. We started a similar kind of initiative with Indian Institute of Sciences and developed this MIDAS platform, which Dr. Manish was saying. This paper is in Nature Medicine. So we developed this initiative where we are trying to develop thematic gold standard data sets. You can say gold standard. We are using word gold standard, but you can also say benchmark data sets. Data sets which are representative, data sets which are highly curated, annotated, and relatively unbiased. Not 100%, relatively unbiased. So we have released two data sets. One is on oral lesions, where one can predict oral cancer from the lesions, and second is dural lesions from before brain tumor, which is used for treatment planning and so many other things. So those both of these data sets are available. Website, I think I have not written. It is midas.iisc.ac.in. Both of these data sets are available on that platform. And we have also now in the process of creating more such data sets in the area of tuberculosis, chest TB X-rays, in the area of mental health, which is a very big area we are trying to address. Anxiety, depression, from the facial expressions, can we predict that from the video? And then there are challenges in that. So if you have a video, how you will take care of the digital privacy and data protection? Because you have a video face. But then there are technologies to tackle that as well. So you can convert the facial features into a vector, numbers. So there are technologies which are available. So I think that's all. This is what I wanted to share with you. Altogether different world, which is different from DNA, protein, expressions and all. But it is again a very important world, and we need to work on that. And with these words, I would like to use this quote that digital health leadership belongs to India. You all will agree with me. If somebody has any question about it, I am open for discussion. This leadership belongs to India. We would like India not only to become the biggest consumer of digital health tools and technologies, but the biggest creator of digital health. This quote is actually a modified version of what Professor V.K. Paul has said. V.K. Paul is member Health Niti Aayog. He said about the same thing with AI. But since AI is a technology and digital health is a domain, there is a many to many connection between a domain and a technology. AI can be used in so many places. So I have just modified it because digital health is something that we need for India. And with these words, I thank you all. And you have been a wonderful listener. Any questions? I'm open. Maybe related to this, maybe something else.
Was in lab and then AIMS next door. And when I interact with doctors, I generally find that there is lot of difference between their thinking and our thinking. So how you bridge this gap?
By reading a lot. Because I have to read your area, I have to read their area. If I read both the areas, then only I'll be able to understand what you are saying and what they are understanding and what they are saying, what I have to make you understand. I have to read both the areas.
Regarding these digital hospital, and you also mentioned that there is a issue of regulatory phenomena over there. I know several companies which are coming up with these developments, but I'm not sure about the regulatory phenomena working over there, or is there anything somebody develops, because I know a couple of people who are developing this in collaboration with hospitals. At one end, they will have a panel of probably doctors, and then the actual patients in their place. So while that connectivity and flow of data information will happen, the regulatory one aspect, what is it? Do you go
2023, we had this DPDP Act, which is there, already passed by the Parliament. And then now this year, we are in the process of developing rules and regulations for that act. Interesting piece of work, because it is going to work at both the ends. it is going to preserve the privacy and protecting the data of individuals or patients. But at the same time, there are some exemptions for the research. We are trying to expand those exemptions a little bit more so that development can happen at both ends. We get innovation, at the same time we protect the privacy of individuals.
That's very important because I mean, whatever tool is being developed right now, I would consider it to be a development phase only, even if the companies are doing it. They will change, they will evolve a lot. When this
So DPDP compliance is one thing, and then the tool has to be approved by CDSU. So CDSU has 4 categories: class 1, class 2, class 3, depending on the sensitivity and the impact that tool can have. So we have to go through that process: CDSU approval, DPDP compliance, and then certain compliance. There are regulatory structures available.
Long AI to pass through this medical equipment regulation.
CDSU. CDSU. Some student asked me a question while I was giving this AI lecture and all. He said, "Do you think AI can take over humans?" A very interesting question. I'm sure some of you must have been getting the thoughts of Terminator movie and all. Hai na? Yes, please.
So mine is not just a question but a concern also. If we are developing a AI model or tool for healthcare, so there is a means what I can say is, as a physician, sometimes he need to see patients in front of him. He need to touch also. He need to use a stethoscope also, but we can't bridge that gap. So this is a disadvantage. Second, when you talked about the primary, secondary, and tertiary care, so AI can be well implemented in primary care. When we talk about the severity of the patient, can AI tools can be manageable in detecting the severity of the patient just by taking inputs? Because let's say if there are two persons, A and B, one is marked by acidity and second is marked by asthmatic patient. Both will say that I have difficulty in breathing. Can AI can manage to differentiate between aspects of severity? My third question is, if let's say we develop a model and let's
यार
say
मेरी एज का ख्याल रखो, 3 इकट्ठे मत करो, एक एक करके दो तो मैं आंसर कर पाऊंगा. पहले मैं सेकंड का आपका आंसर कर देता हूँ. देयर इज अ वर्ड कॉल्ड पेशेंट ट्रायजिंग. So there are AI applications which are being developed. I know a couple of companies they are developing, and in fact at eSanjeevani also we are in the process of developing those. Where rightly you said that some individuals symptoms are similar, but one disease is very serious and the other one is not that serious. So that is called patient triaging. So if patient triaging, it is very easy to do with the AI. But then the tools have to be properly validated. It's not just we develop something and then implement. And what was your first question?
bridge the gap. Sometimes
I
physician.
agree with that. Now I remember. The touch is actually not there with telemedicine. I agree with that. But you think of the advantage it gives to providing healthcare services to masses. If we wait for touch, we cannot increase the number of doctors overnight. But the patients are there, individuals are there who require medical attention. So there, some cost benefit we have to look at.
So my third question and last question was that, if let's say a successful AI model is built for the population of India, and let's say that AI model is prescribing able to prescribe medicines. So, but there will be a danger that the prescription provided by the AI is as dangerous as self-prescribed.
So that is not there. Prescribing medicines, that is not there. The therapeutics thing that I just talked about is actually providing consultancy or kind of providing advice, guidance. Mostly these therapeutic things are in the mental health area. But prescription is a very, very dangerous area. And I think there, human in loop, the word is called human in loop. That is absolutely required. Doctor has to be there to supervise.
Hello. Am I audible to you?
People generally ask to AI, like this question comes right now. Tell me the future date when all the health problems end.
As long as
What
yes,
would you say? What AI?
हो नहीं सकता यार. The problems will remain, but the nature of problems will change, may change. It's not that we should not say it's problem. We said challenges. Challenges will remain. They will change their nature, but it will remain there. Totally disease free नहीं हो सकते बस.
Sir, can I ask a question, sir? Yes. Hello.
AI कोशा. I completely agree. We need to bridge this gap. For proper translation, the researchers, the doctors, and engineers, that gap needs to be bridged for translation. You know Dr. Vijay Raghavan? Okay. So Dr. Vijay Raghavan, when he took charge of DG ICMR, he took charge for a couple of days. He came to ICMR, gave a lecture, and at the end he said a couple of words which I liked, and I'm quoting him. Researchers innovate, engineers develop, doctors use. When you have these three proper put in place, you have all the world translation. Researchers? Bioinformaticians are researchers.
I just have one simple question here.
Okay, yes, please.
We have something just like we have clinical trials in case of drugs or vaccines. Is there a similar, regime for testing these? I mean, just validation is something very simple. Validation can be done with some data and all, but do we test it through some rigorous procedures like clinical?
There are efforts going on worldwide, not just in India, worldwide, to regulate this AI and digital health tool and technologies, and to scientifically validate, properly, thoroughly validate. That's why I said there are 4 levels of validation. But right now, I have not come across a very serious kind of validation protocol as we have for the drugs and vaccines and other things. But it will definitely come.
Yeah, because I think if we do not have that, in absence of that, we are probably getting swayed by what you can achieve, and we should not, turn a blind eye to what we are losing in between. So,
Yeah, but
one
it
should,
is,
I think, pay as much as important attention to testing these things in population before actually launching them for use.
madam, it is there. It is there already. I'm not saying 100% it is not there, but the level is improving. So there are the CDSO, which I told you just now. CDSO has these classes, class 1, class 2, class 3, class 4. So there are some regulations available, but those needs to be evolved. As with the clinical trials, clinical trial protocols which are right now, are not developed, they evolved. So similarly, this is also evolving, this area.
Can I have one more question? Do we have time?
Okay.
Sir, actually, I was just wondering, is there any effort on base of AI methods to combine traditional medicine with modern medicine?
Oh, yes.
Because like I had found a few books when I was abroad which says that Chinese people, so there were doctors from America who had gone to China trying to figure out the symptoms and what medicine was prescribed for those symptoms and what they would prescribe in American medicine. So is there effort of that kind where AI can be helping?
Absolutely, there are efforts ongoing, ma'am. Okay. And the department which is looking at is Ayush.
Yeah, I thought.
Yeah, they are already, couple of projects, couple of programs they have already started. There are.
Comment on this. I think in Japan, you have practitioners who are actually suggesting both.
I can imagine.
Both modern medicine as well as their traditional medicine. So
and then the AI. And then the AI.
And then the AI.
Then the AI.
Absolutely.
So, Dr. Sab, I have to rush, otherwise
Sure.
I will be late for another meeting. And that is वो आप समझ सकते हो वहाँ बड़े साहब बैठे होंगे.
Sir, just online questions, just one.
Just one.
Anshita Washington is asking, how can we ensure the success of AI in health when the data sets we need are not always open access? Mostly for cancer, the data is always there. But lately, she feels that there is a lack of open access Indian population data for disorders like PCOS. So even if data is there on databases such as GEO, it would be very less. So how do we overcome this challenge?
That is where we are different agencies. I'm not saying only ICMR, different agencies are working towards that goal. There are a number of Government of India initiatives like AI Kosha is just mentioned. Then there is a data.gov.in platform by the NIC. And then the platform, MIDAS platform of ICMR. DBT is also working towards developing, this IBDC. So there are agencies who are working in that particular area. And hopefully in another 1 year or 1.5 years, we'll see fruitful results. Thank you. Thank you. Dr. Manish, you can share my email ID. I'll be happy to answer questions from online participants to email. Because there's a paucity of time. I need to.
So, thank you, Dr. Harpreet Singh, for giving us this wonderful lecture. So, right now, I like to welcome Professor Manish Kumar to give token of gratitude to Dr. Harpreet Singh. Everyone, please stand. We can take a photo. Online participants, you guys can also open their cameras also. We can take this issue. So we are in short of time. So please enroll for our next program. That is about, we have a collab with PDB KV. So please fill this Google form, and we will share it in next month. And after that, these are our social media handles, and please fill this feedback form also, everyone. Yeah. And thank you, online participants, joining for this wonderful event. And please fill this feedback form, and it will help you to gain a certificate. Thank you, everyone. So whoever the questions, we will share the mail ID of Dr. Harpreet Singh. You can ask with him in the Gmail ID. Ashita, did you take the screenshot? Please reply in the chat box of the participant's camera. Reply in the chat box, Ashita. We will share the email ID with the certificate. We will share the email ID certificate.
फिर समझ लेके आओ घर से जो लिखी है यार नहीं आना चाहिए मेरा वो है
अभी बन रही है चाय नहीं बन रहा है तीन चार चीजें देखेंगे क्या हो गया
इनके पास पैसा ही नहीं पहुंचता है आप लोग से कहो ना जब मैं ये चाय पिलाता हूं सही बात बता रहा हूं
अरे बड़ा आदमी बहुत जल्दी है मोदी के पास
सबको पता है वही बोल रहा है कोई सुनने एक कर
छतरी कहाँ रखनी है पेन ड्राइव
एक एकड़ कम होता है
ये अब अपना लास्ट का इसी लग गया
हां
तो
लग गए
अच्छा वो सेंटर वाला बता दो सेंटर का देते करता ही नहीं कितने लाना
पूरी समय बाहर चली गई हां बाहर गई इंसान तो क्या है नहीं
बाहर है
सर एक मैं बात कर रहे थे सर से मेरे इनसे बात कर रहे हैं गाड़ी खड़ा
इसका उल्टा काम करता है ना ब्लैक एब्जॉर्ब की जगह इसका रिफ्लेक्ट करता है
नहीं वो पीछे नहीं
अच्छा इन्वेस्ट करना
ब्लैक में इन्वेस्ट करने के लिए पहनते हैं
वैसे तो लोग मोटे लोग ज्यादा पहनते हैं
ब्लैक पहनते हैं इससे कोई मतलब नहीं है
ऐसा
ब्लैक मैंने बोला है इसका मतलब ये नहीं है ठीक है नेट अप्लाई होता है
एक विचार है कि यहाँ से कोई जाएगा नहीं रह जाएगा क्या कर
नहीं शायद तो अगर कुछ करके कुछ लास्ट पे काटते हैं
अबे यार इसको